So first off, I was just wondering if, you can take turns, if anybody wants to comment on the issues and challenges around funding. We've heard compliments to funding that has been achieved, but I mean, can you expand a little bit more, particularly for those who might not have been involved in Indigenous research, what some of the issues and challenges and hopes are?
I have a couple of things I can say.
Sure, go ahead.
So I just have a couple of things. Vis-a-vis CIHR, I would say part of the challenge, well, on the positive side, what's been helpful is specific programs. I mentioned the Resilience Project, other implementation research teams. So there have been specific opportunities the institutes have created that were extremely valuable because it's not always clear that an independent proposal just thrown into the soup would make it all the way through without that kind of existing framework for things. So that's an issue. In terms of the Public Health Agency of Canada, I'll mention that we had enormous problems with a multi-site project trying to funnel money into communities and being asked initially to have quarterly statements in which we end on zero every quarter. It was just this side of complete insanity. So we fought for years to get greater flexibility in terms of how money would flow, just to allow communities to do the practical things and deal with all the stops and starts and so on that are inevitable in this kind of research. So I'll just mention those two things that have been important for us.
Yeah, so I agree. I have my view, some things that I'll just, so before CIHR, so like when Henry Friesen, started CIHR, so like at the time it was so controversial to have an Institute for Aboriginal People's Health. I don't know if many of you are not old enough to remember, but there were that in those days when there was the transition from MRC to CIHR. But I think in retrospect, and so I was actually a charter member and Jeff invited me to be on the Institute Advisory Panel, like the very, very first one, and then setting up these, cadres and training programs and so on. And I think in retrospect now, we've seen, the benefit of that and of having that. So I think in general, like CIHR in general has had, there's the general issues of funding of research in Canada, and so that's really then also been reflected in funding for this area. But if I then go back to the sort of the prehistory of even beforehand, it certainly has moved forward. The hope is now that we are, with the current, government and leadership and, what we've heard and all the promising signals that we're maybe in a new era for research in general, but then for this area in particular. And so we hold out hope. I guess for all of us who are in research, we always have to hold out hope, and now in particular.
Thank you. I think one thing you can count on, this is the audience that's old enough to remember. I think, Charlotte, did you want to add something?
I remember. I'm very old. And so I guess two things that I would say we're all sharing these challenges, not just, in Indigenous health, but I think CIHRs and the rest of us are, which is that this is a fairly new undertaking. So before 2000, I remember when I was starting my doctoral research, I was looking at the menopausal experiences of Mi'kmaq women, and people were like, what? So there was little understanding about how culture informs experience, even something that we think of as a medical experience or physical experience. And so I think because we've been engaging in research, and I really do have to acknowledge Jeff in that, I think that as the inaugural scientific director of CIHR, he was instrumental in changing the landscape of Indigenous research across the country. And even though I'm still married to him, I'm not saying that just because I'm trying to be nice. Jeff can tell you I'm very rarely nice to him. I'm joking. And so I guess I'll leave that to you to tell them later behind my back. But what I'm saying is that because it's a fairly new endeavor for all of us, the landscape is changing, not just for the funders, but we ourselves are learning new things about how to do good research with our communities. And so as we learn, we have to convey those expectations onto funders and peer reviewers. And so we're all, I think, learning together. And I think really what the challenge is that we all understand that we're trying to catch up for a very long absence, in this whole endeavor. And so I think we can, I think a little patience and humor and, dare I say, love and compassion. I guess I can't say that.
Not in the research world, but so it's been clearly described to us today that this is potentially a new opportunity with the new government, the new attitude, the Truth and Reconciliation, some momentum going, if you would. The Academy has expressed an interest in perhaps focusing on this as a topic. What advice would you, as successful researchers of projects, would you give to moving forward? Where should the Academy go to try and focus and facilitate a stronger research agenda moving forward?
We're all buying time. We'd all like more time to formulate an answer. Well, for me, I think, and it's related partly to the whole discussion this morning, I don't think this is just about choosing topics driven by, basic science questions or even urgent health questions per se in terms of services, but more about structural issues, about identifying where there need to be changes and how things are done. Because the biggest successes we're alluding to were essentially about that, creating the Institute of Aboriginal People's Health, creating community-based review of processes, articulating a form of ethics and practice that involves true partnerships with community. These are processes in a way that are different, and they have their own benefit, whether or not and this has been our experience with the research, whether or not the project pans out exactly the way you want, the process of engagement, the capacity building and so on is palpably meaningful and significant in what we're doing. So thinking about ways to really build that in more widely, both into research and into health services, I think would be number one priority for me.
And then I think also choosing, I don't know how to do this, but choosing some early wins. I mean, things that would have or like whatever agenda items or prospects or programs that would have a high feasibility and high probability of early success that could be, early pilot progress and then even, successful outcome, and maybe just focusing on a few, like not like the tendency would then try to be, all things to all humans, and really just to maybe keep it focused on a few highly feasible things. But what those would be, I can't comment without sounding, so I could be self-interested, but there are, there's obviously, you could all think of examples.
You still have a gene or two to discover.
Yeah,
okay.
well.
If I could actually say one small thing about that related to pilot projects, I think for many communities that format is deeply problematic because a lot of funds flow through, somebody does something, and then it just all falls apart. So somehow, and this again is a good thing for the society to think about, how could things be coordinated at a higher level so that the generation of research and the institution of ongoing programs is somehow better linked, and it's not up to the individual community or individual investigator to make that argument, because it's daunting for most people. They don't have the resources.
I'm kind of shocked that nobody's brought up the issue around funding for communities. I mean, the cost of doing research involving communities, the fact around the need to do capacity building and thereby having enough funds to hire and train people and sustaining communities, because and the travel costs that are associated with we've seen the maps of the Indigenous communities across Canada. Does anybody want to comment on that?
Well, I guess on a related note, I guess one of the things that I like to remind people of is that this is what we do for a living, most of us. And so the folks that we're engaging with in the communities are already making a living doing something else. And so when we come with our good intentions and say, we're going to, guess what, good news, we're going to do some research. And they are doing this off the side of their desk, off a very full desk. And the notion of capacity building is an interesting one in the sense that we often imagine we have skills that the community wants. It'd be like going to, in some cases, people do want those skills. They say, yeah, we would like to do our own research. But a lot of times, if I take my car to a mechanic, I say, I don't care how you fix it, just do your work and service my car. And so in many cases, if we think of ourselves as service providers, it changes the role. And so there's not so much focus on, we have some skills you'd like. Now, if, in the case of the women that I talked about, some women said, listen, I'd love to know how to do this, or facilitate a sharing circle, or take interviews, but we have a lot more to learn. I can tell you that Doris Pelletier, the woman I spoke about, has been one of the most important mentors of my research career, and I have been doing it for a while. And so, because she's taught me how to really listen and how to really understand that I'm learning more than they are. And I think that's probably one of the funding, yes, of course. And again, it's in addition to the funding, it takes a lot of time for the community members. We think, oh, lucky them, they get to do research with us, but it's a burden. It's also a burden, even though it's something that's needed. So we have to think about how much time, how much money do we really have to put into these things?
That's a great response. I think we have a couple of minutes. If there are any, I would plead that if we can get some roving mics. Questions, not comments, please.
There's a mic here.
Okay, sorry.
Yes, I was very interested by your last comment, and I think that the issue here, maybe we could change our terminology instead of capacity building. I've been involved a lot in India with communities, and we changed the language to talk about knowledge enhancement, because we learn as researchers as much as from the communities as the communities may learn about research from us.
Mm-hmm. Good point.
Great. Go here first and then back there.
This morning, Dr. Smith spoke about the going back up and down from the top of the cliff to the bottom of the cliff, and I think that even though the idea of projects or programs are sort of, the question was raised about their impact. To me, one of the chief issues is the sustainability. So if a research group goes into community and gets resources to be invested in the community to develop a program, and then at the end of the funding of that project, the resources are withdrawn, the impact is really doubtful, if not negative. So, I think that it's a critically important thing to think about at the beginning of the program, where are the resources going to come from, and to get the buy-in of deciders, whether they be the people responsible within the health zone or at the national level, at the ministerial level, to think about how this program, if it is successful, how it will be sustained.
And I think the next program, the KSDPP project, is going to be a testament to strategizing for sustainability, because it's been a huge challenge.
Could I just make a very quick comment, or just a response to your comment? Is the Visioning Health project that I was talking about? We actually engaged Aboriginal Aid Service organizations early on, and communities where these site meetings were going to occur. And one of the main features of those discussions was, how can we sustain this as a project? And so that's why the training manuals being developed, because they've all bought into, or they've, what's the word I'm looking for? Nope, that's not it. Yes,
Jeff?
they've made a commitment. Thank you. That's 14 years post-menopause for you. I'm joking. They've made a commitment to doing that, so.
Thank you.
Doug Wilson from the University of Alberta. We've heard some really innovative ideas about progress in these areas. We all work in academic institutions, and we haven't perhaps talked very much about what organizational structures and processes within academic institutions are required to develop successful relationships with with Indigenous communities. We've got a lot of structural and process issues within our universities that don't foster developing strong relationships with Indigenous communities. I don't see us changing very much unless we take some internal actions around that.
I would add that perhaps the greater challenge in creating relationships and education happened with us investigators at our research institutes, not with the communities. But I think that's a really important point.
Question for Rob Hagley is Paul Armstrong. Rob, coming back to our president's opening remarks and the search for solutions, you've given us an elegant sojourn down the balance of nurture and nature. Now take your 2 decades plus experience and reflect on going back to the community with your genetic insights and tell us, 1, how that has modified the delivery of healthcare, 2, how it's modified health behaviors, and 3, how it's modified health outcomes.
Yeah, well, I think so with Sandy Lake. I mean, this was the collaborative project with Stewart. So I think just taking Sandy Lake as an example, so they feeding back to them as soon as we learned that there is a genetic component, not for the whole issue of diabetes, and we continue to look for, but nothing as strong as HNF, but there's a genetic component, but there's more than that. And so then this has led to a community-wide, intervention study. And so can you describe how that's going?
Yeah, I think that when we published the prevalence rates of Sandy Lake, which at the time were the 3rd highest published rates of diabetes in the world, the deputy chief that Rod alluded to, Harry Meekus, was interviewed by the Winnipeg Free Press, and they said, so now you're famous as having the 3rd highest rates of diabetes in the world. And he said, no, we're going to be famous as the first community that did something about it. So they actually reversed what the media was going after around the issue, and they have. I mean, it created mobilization. They built walking paths throughout the forest. They used to actually have walking paths because it's like it's very boggy. It's a marsh, and there was no place to walk. You took your own life into your hands if you walked on the road because people come speeding down that road. So people didn't walk. So now they created and used other resources. Summer programs hired students to build walking trails throughout the whole community that are still in place today and every year are getting added onto. They worked with the northern, many of you have heard about the high cost of food, etc. It's always in the news, to try and put labels on what were healthier food choices, and managed to we demonstrated that they reduced the amount of soda pop, quite dramatically by increasing and showing the same equivalent increase in diet soda pop, but just by community awareness. So it's an example, I think, of the community taking the knowledge and building upon that.
One final question.
One final
Thank
question.
you. David Gregory, University of Regina. So really excellent panel discussion and presentation. When we're talking about communities, are we also including the urban centers? Because almost all of the examples today have been geographically distant from urban centers. So I just would like that clarified. Thank you.
Yeah, we have to. I think there's not a lot of. I mean, there are some exceptions that has not been studied. Those iterations of communities have not been as well studied, but that's absolutely as high a priority. And going forward, I think that's an opportunity.
Yeah, we know much less about, although 51% or so of people, or Indigenous people living in cities, we know much less about the health of that population because they're not identified as such necessarily, and a few people might go to a friendship center or do something else, but there's no easy way of capturing that population in most cases. So we have almost no data on that, nor is it obvious that a one-size-fits-all approach will work there, because again, in most cities, that's a very diverse population of people from very different places.
And yet in the case of HIV, it's probably the opposite. We probably know more about HIV among urban dwellers than because many people living in communities either don't have access to testing, or because of the stigma attached to HIV, they don't get tested. And in terms of the Visioning Health Project, there's I would say probably an equal number of urban and rural or remote sites.